Good morning. Just so I know who I'm speaking to, because obviously you saw me arrive very, very early this morning. Are you all year 2, 3, 4 or different years? Different years? Okay. Well, it's lovely to see you all, and it's really, really, really lovely to see that you're interested in doing paediatrics, because we need lots of paediatricians. No, never more so than currently right now. I work with my job here this morning is to talk about being a neonatologist, but I also work with the Royal College, and I'm the training programme director, so I kind of am the man who organises people's training within Cheshire and Mersey for registrars or ST4 to 8s. And I can tell you that at the recent interviews nationally, we have appointed enough paediatricians for Liverpool and Mersey, but in places like Leeds and East Midlands, they've only appointed 50% of the number of paediatricians, and there's still children being born as far as I'm aware, so they still need looking after. So I'm never quite sure what I'm supposed to talk about when I come to events like this, so I'm going to talk about myself to start with. Please don't see it that I'm bragging, it's just that it explains how you get to be where I'm a neonatologist. So that's where I work at the Women's. I don't work here. Some of you or all of you should have rotated into this building. Can you hear me without? Is it better with, or doesn't matter? Yeah, it doesn't matter. So that's where I work at the Women's. You'll hear the talk about closing the Women's, moving the Women's, merging with Alder, the Royal. All I can tell you is we're about to build a brand new £15 million neonatal unit at that building. So it's there for the foreseeable future. I trained at the University of Liverpool as well, and then went on to postgraduate training around here, and I always wanted to look after children, and I was probably like you. I thought when I did this presentation, why was that? And it's because the real reason for me is children were honest. They're sick when they're sick, and they're well when they're well. So they don't, Gavin's probably got patients who this doesn't apply to, but certainly for lots of areas and most areas of paediatrics, children don't swing the lead. When they get better, they want to run around and play, and when they're sick, they just lie there and they let you know that they're sick. And I like that in children, as opposed to adults, where they can make up all sorts of symptoms and signs. And I'm not saying all adults are dishonest, but I like the fact you saw rare stuff, and you also saw common stuff. So you could get used to certain presentations of patients, and then every so often, within that realm of usual symptoms and signs, there'd be some clue that something's not quite right, and it'd be something really weird and wonderful that you'd never seen before, and that maybe nobody in your hospital or even your city or country had ever seen before. I like the fact that when you train, you could either end up being a generalist, so looking after all children, and with all conditions. There's very few parts of medicine now where you end up looking after the whole body. You end up looking after the left knee or the right knee or the ears, whereas in paediatrics you could look after the whole child and their family. I thought paediatricians were generally nice people. I suspect you wouldn't get 5, is it? Quite eminent consultants coming to talk to some students on a Saturday, giving up their time for free. If they were adult physicians, they'd probably want £150, £300 for a presentation, whereas the paediatricians are generally nice and will come and do these sorts of things for free. And I'll probably find there's a check outside. No. And it's a very rewarding job working with children. So as a student, I did an elective in Belize, which is a small country in Central America. I did an elective at Great Ormond Street in cardiology, which was really interesting, but made me not want to do cardiology. I did 4 months paediatrics as a PRHO, which is your equivalent of FY1. And way back then, you either did 6 months medicine and 6 months surgery, and they just introduced these posts where you could do 4 months paediatrics as part of your 12-month rotation. And not to embarrass Gavin, but he was one of my registrars back then. And then I did ST1 to 3 or an SHO PEDS rotation in this region, and I loved all of my posts. I loved every one that I did, and the difficulty was everyone I went to. So I did oncology and I wanted to be an oncologist. I went to general paediatrics, I wanted to do general peds. And the last 6 months were intensive care, neonatal intensive care. And as an SHO in neonatal intensive care, I was looking after patients a little bit like this. You can see how small that little girl is. I'll tell you a bit more about her later. But it was really, really busy in intensive care. We were looking after tiny sick babies who didn't communicate with me. So I wanted to look after children because I thought they were lovely and cute, and they ran around and they spoke to you, and you could play with them. You couldn't do that with these patients. There was lots of procedures. And it was like nothing else in medicine. There's no other branch of medicine that is like neonatology. And we have paediatricians who come and work with us and are a bit shocked by what happens in neonatology, by the size of the patients. And it's like nothing else in medicine because we can have patients next to one another who are 10 times bigger than their neighbour. So we can have a 500-gram baby next to a 5-kilo baby. In the smallest of babies, a fluid bolus will be 4 mils of fluid. Now, that's in an adult cannula, that's less than a flush, but that's a fluid bolus for one of these babies. We're prescribing tiny, tiny doses, and we're working on these tiny babies, and nothing is normal when they're premature, because how would I know what a normal blood pressure would be for 20 to 22-year-old medical students who are interested in paediatrics? What would I do? It's a really easy question, that.
Get a load of medical students
in a room, yeah. Measure their blood pressure, find the ones which were healthy, put them all together, get a normal distribution, and say, yeah, that's a normal blood pressure. The problem is with preterm infants, by definition, none of them are normal. So we don't know what a normal blood pressure is. We don't even know what blood pressure we should run them at to get a satisfactory outcome at the end. And we don't even know if we should treat that blood pressure. So we're flying blind on a lot of things. So there's a lot of areas for research in neonatal medicine. And I absolutely hated neonatal medicine as an SHO. So all these posts that I really liked, interacting with children, did this one, didn't like it at all. And then I came back as a registrar. And when I came back as a registrar, I realised that the procedures that I couldn't do as an SHO, I could now do. I liked it because the patients were sick. So I knew when I went to work, and this is a really weird thing about being a doctor, you get a kick out of other people's children being really sick. It's really sad, isn't it? But we don't go to work to walk around and see well people and go, hello, good morning, how are you? We go around because we want to make those sick people better, or sick children. We have lots of emergencies. There's lots of ethics. We're dealing with young parents who on the whole are really appreciative of what we do. And it can get quite complex. So I decided I was going to do neonatal medicine. I did some research for 2 years, and that led to a doctorate degree. Did what we call grid training in paediatrics, which I'm not sure if you're aware of. But that's where you do your general paediatric training, you do 2 years at ST 4 and 5, and then you might want to sub-specialise to become a neonatologist, a paediatric respiratory physician, or rheumatology, and you have to apply nationally, and then you get on a grid training programme. And we've got quite a good success rate for trainees in Liverpool of getting them onto grid training. And I trained in Liverpool and Manchester, and then became a consultant neonatologist in Liverpool, back to looking after these little people. So here I am back in Liverpool. This was about 8 years ago. I've been a consultant now. And I thought I would tell you about a week on the intensive care unit. Now, this wasn't last week, but it was a real week. It was a week that I presented this presentation a few years ago, and it was the week before I did that presentation then. And the first patient I want to tell you about is Willow, and this is Willow. And I met Willow while she was still inside her mum at 20 weeks gestation. And her mother was 25 years old. She had an 8-year-old girl who was alive and well, and she'd ruptured her membranes. So her membranes had gone, the liquor was draining. And so I told her that the problem you've got with this is that the risks will be you'll go into preterm labour, you may get an infection, and there might be a problem with babies' lungs, because babies need fluid around their lungs to help breathe. About 3 weeks later, and it was on the 29th of December, something like that, she presented with green discharge, so she got steroids because we know they improve the outcome for preterm babies. And a baby girl was delivered. She cried, she was intubated, got surfactant and went to the neonatal unit. And she weighed 383 grams and had a head circumference of 18.5 centimetres. Now, I'd never seen a baby this small. So 383 grams, how can you conceptualise that? It's really difficult to conceptualise it. So some of my colleagues laugh when I give this analogy, but you know when you go to the supermarket and you buy a small pack of mints, that pack of mints weighs 500 grams. So take 2/3 of that, roughly, and mould it into a baby. That's what you're dealing with. So you're dealing with someone who's about that big. Okay? And that's her there. So they're not my hands. My nails are better manicured than that. But these are the dad's hands, and you can see on this little baby we have... Hang on. Oops, that's not working. It's on here. Anyway, you can see that we've got tubes into the belly, into the umbilicus. We've got cannulas or long lines in. So this is probably a line that's fed in here, with a line leading all the way up into the inferior vena cava. We've got tubes going into the lungs. Sorry. So when I first met this patient, what did I think? What did I tell the parents? And what did I do? So when I said to you that she was 23 weeks and weighed 383 grams, did any of you think anything, or was it just you'd never seen anything like that, so it didn't mean anything? What did anyone think?
That's really, really tiny.
Yeah.
Really tiny.
Yeah. So that's what I thought. So I thought, I didn't voice these thoughts, but as I walked around I thought, why was she resuscitated? Babies of this size and gestation don't survive. This was 8 years ago, so certainly of this size, certainly 3, I've never seen anyone that small. What do you do? Well, she seemed alright, so let's carry on till something bad happens. And then when bad happens, we'll deal with it. And why do we think that? So we think that's me before I went bald at the bottom. That's one of our neonatal nurses, and that's our whole team of nurses. So we base all these thoughts on things we have seen in our own practice, but can we base our opinion on our own observations? Well, not really. If we think about how many babies are born in each hospital, there's around about 0.08% of live births occur at or below 23 weeks. So each small neonatal hospital or maternity unit is going to see 2 to 3 of these babies each year, and the smaller units are going to ship them out to larger units like ours. So if you've seen one of those 2 babies live or die, your own personal observed survival is 50%. But that will not reflect, obviously, larger numbers of babies. So instead what we do is we look at national data, and the classical outcome data trial studies for preterm infants are the Epicure 1 and Epicure 2 studies. And if you do paediatrics training, everyone needs to know these studies because they tell us the chances of babies surviving at certain gestational ages. The problem with them is, you can see Epicure 1 was in 1995, so the people who were in that study are now 22 years old, 23 years old. Every baby born during that year was recruited who was less than 26 weeks, alive at the start of labour, and they followed how many made it to be born alive, how many made it out of a neonatal unit, how many ended up with neurodisability at 18 months, 3, 5, and they're now following them up at 22. So they're sort of around your age, I guess. Some of you were probably born in that year. And they found that interesting things, like we know the survival figures and all that, but more interesting to me is you'll find preterm infants are less likely to be in jail, and they have fewer friends, and the thought is because their social skills aren't as good, and they go out and they drink less, so there's they're more likely to have lots of other problems like mental health illnesses and so on, apart from the neurodisability stuff that we know about. So because we now have 21. But these outcome data for 2006 are now 10 years old, and I can tell you just from my anecdotal experience that the survival of preterm infants in the last 10 years has increased dramatically. Now, whether or not that relates to increased figures throughout the country, I can't tell you, but I suspect strongly it does do. So we use these data to tell us the chances of babies surviving. And if we look at these data, if you look at 23 weeks. If you make it to a neonatal unit, then your chances of making it home on that slide are around about 30%. So here's the Epicure 2 data in a bit more detail. So if you're alive at the start of labour, you have a 1 in 6 chance of taking a baby home at 23 weeks. Now, look, these numbers aren't quoted very often, but I think they're very interesting. So these are babies that are born alive, and these are babies live with birth with intended care means that there's been a discussion about us intervening and resuscitating that child. So the interesting point for me is 15% of 23-weekers don't get resuscitated or weren't resuscitated in 2006, even though they were born alive. And why is that? So 1 in 6. And this lady from Canada, who's a neonatal ethicist, has a really interesting point of view and says there's no official policies or professional association guidelines suggest an age limit for resuscitation apart from preterm infants. So we seem quite happy to discuss not resuscitating infants at 23, 22 weeks gestation. Yet if I was to stand here and say we're not going to resuscitate anyone over the age of 70, there'd be an absolute outcry. So why might we not resuscitate them? So the first reason we might not resuscitate them is this document, which was published again around about 2006. So it's again quite old, but this stated different gestational ages what you should do. And for 23 weeks, it says that precedence should be given to the wishes of the parents regarding resuscitation and treatment. Do you think that's right? Yeah? They're the ones going to be looking after the patient. Maybe. We'll come back to that in a minute, I think. So the second reason it might not be true is... just going back to that. So how do parents make their decision? They make their decision on the information I, or we, give to them. And I could say to them, your baby has a 30% chance of making it if they make it to the neonatal unit. It's going to be difficult, but 1 in 3 of them are going to make it. Or I could say to them, your baby's got a 1 in 6 chance, because it's alive at the start of labour, actually making it home. They're going to have months of intensive care. It's going to be really, really difficult. Some people would say it's torture more than treatment. Do you really want us to do this? That's exactly the same information with the same data. It depends on the spin the doctor gives it to them, and so therefore you have to have a very balanced approach with the information you give to families. The next is the self-fulfilling prophecy, which occurs in medicine all over the place, and you have to be aware of this, whatever branch of medicine you go into. And this goes that doctors and nurses, certainly at the Women's Hospital 8 years ago, used to say, most 23-weekers die. Therefore, we shouldn't resuscitate or treat them aggressively. So what do you think happens? Most 23-weekers die. So therefore, we shouldn't treat and resuscitate aggressively. Then most 23-weekers die. So you need to break that cycle. So going back to these infants who we try and do something with at 23 weeks, say we try and resuscitate them, what's the chances of them making it, being it successful? By successful, I mean you get them to the neonatal unit and the parents get time to spend with them. So 75%, 1 in 4 of the babies who we try and resuscitate at 23 weeks will be admitted to the neonatal unit. And so I'm going to say to you, for the babies who we try to resuscitate, is that a worse outcome than not having tried at all for the families? So the third reason why we might not resuscitate these preterm babies is, do we value the life of an extremely preterm baby less than older children or adults? Who immediately thinks yes, who immediately thinks no, and who immediately thinks, I don't know? He thinks yes. Good. 2, 3. He thinks no. 1, 2, 3, 4. More people. Who doesn't know yet? Lots of people. Medical students, I can't answer in case I'm wrong. There's no right and wrong in this. So we'll have a little quiz then. And this quiz was based on, it is a research study. And they asked 524 doctors of students of law, ethics and medicine this question. You're in charge of an A&E department of a busy hospital. You can't resuscitate all these patients who all arrive at once. I'll show you a list of them. and in the following patients, who do you deem it not in their best interest to resuscitate? And you would accept if the family wished to withhold care. So if the family said, I don't want you to resuscitate, you'd go, yeah, I agree, that's fine. So here's the list of patients, and I'm going to give you about only 3 or 4 minutes to discuss with, in your, I don't know, in groups of 3 or 2, about who of these patients you wouldn't resuscitate and who you would resuscitate and why. Now, it gives you the patient down the left, it gives you the chance they will survive, it gives you the likelihood of a normal outcome among survivors, and it gives you the likelihood of a new major disability. So I've given you the figures, but you need to decide now which one of these you will resuscitate and which ones you won't resuscitate. Off you go, start talking. If you don't make noise, I'll start making noise. Okay, right. So, which of those is the first person you're going to kill off? Sorry, not resuscitate. Everyone kills the granny off first. And is that because she's had a life, she's had her experiences? Yeah. Who's next? 35-year-old. Who thinks 35-year-old? That is a sign of being a psychopath. But if you're basing it purely on the figures, then yeah, most people, maybe you can't relate to being 35. I mean, it'll happen to me in a couple of years. So but most people don't pull off the 35-year-old because it's too close to them. It's too close to where we are. You know, the others 50-odd guys, really old. gosh, who else is going to be 50? 14-year-old, you know, they're all their children. The 8-year-old, yeah. So those who aren't going to kill the 35-year-olds, who are you going to not resuscitate next? I'm not sure. I'm slightly a bit worried that the next generation of paediatricians are all psychopaths. But so when they did this and asked the questions to all of the students, these are the figures they gave you. So just bear with me a second, because it can be a little bit confusing. But the grey bars are where they thought it was in the patient's best interests to resuscitate. So the higher it is, the more likely they are to want to resuscitate. And the black bars are they would accept if the family wished to withhold care. So the lower it is, the more likely they would be to argue against the family. So you can see everyone, let's just look at the grey bars. So in the grey bars, way down here, it's not in her best interest to resuscitate her. She's 80, she's had a life. The next one is the 24-week preterm. Even though they've got the same outcomes as the term infant, the 2-month-old, I think the 7-year-old, or maybe the 7-year-old was worse, and that 35-year-old was way down, but lots of people think, yeah, no, it's in their best interest to resuscitate them. And there's something about the extremes of life, so the extreme age of life, the extreme beginning and the extreme end, where I would say we don't value life as much as we do when it's certainly for children. And for the preterm infants, we see this a lot. We see it a lot both in, and I was talking to 2 of my consultant colleagues about it, because you'll be aware of a very high profile case about withdrawal of intensive care happening in this hospital right now. And then he said, whatever happens in paediatrics usually happens in neonates 5 to 8 years later. And it's relatively easy for us to withdraw care with discussions with families. I use easy in inverted commas. It's never easy, but relatively. We don't often end up in disagreements with parents. And so there's this, why is that? And I think it's because we do value the life of preterm babies less. And I think the reason we do is they've not yet communicated. They've not really built relationships, strong bonds with families. They look completely alien to us. There's no one, it's not like when you're walking around, you see generally tiny babies with thin skin and no muscle and on ventilators. So you've never seen this. It's an alien thing to you. You made the bond might not be as strong. But certainly this research and practice would suggest that we value the life less. And the other way we see it, I spoke about the women's hospital potentially moving. And you may have seen, if you follow the local news, lots of arguments why we should move to the adult hospital, because women in labour need this care and that care, and if they need intensive care, they need to go there. All of those arguments stand for why neonates should be with children's services at Alder, yet those arguments were never heard. Or whenever you speak to policymakers, it's all about women's needs, women's health, yet the really sick group of preterm babies are very rarely mentioned. So it can work both ways, this. What I think, we don't value the life of preterm babies as much as older children and adults. Right, let me just skip over that. So, the relevant question should be not what are the survival and disability data for children born at this gestational age, but rather what would be the chances of survival if we actively resuscitate and provide intensive care. Because if you do nothing, then they're going to die. And we know that. So if we try and treat them, and I'm going to skip through some of these data, but basically if you're at 23 weeks, 10 years ago, if you made it to a neonatal unit, the chances of survival were 30%. Now it's probably about 50%, but I haven't got the data to back that up. So I feel comfortable resuscitating 23-week babies because 75% will be successful. By that I mean we'll get them to the neonatal unit. And 1 in 5 will make it home, and if they make it to the unit, 3 in 10 are going to make it home. This is based on data from 10 years ago, and I'm going to say it's probably almost certainly higher than that. So the next thing everyone tells me is, but these 23-weekers are damaged. The worst people to ask this question of are the paediatricians, and particularly paediatricians in an intensive care unit in this hospital. Why do you think that is? Exactly. Who said that? or what job do you want? Paediatrics, you can have whatever job you want. That exactly, you're spot on. So what do parents want to know? Is my baby going to survive? And if they survive, what sort of life will they have? And there's lots of figures on here, but we'll just jump to this slide here. So this is, if you're born at certain gestation and you are alive at the age of 3, do you have mild, moderate, no or mild disability or moderate or severe disability? Mild disability in here would include things like slight difficulty with hearing, needing a hearing aid, or needing to wear glasses at the age of 3. So they're not, we're not talking severe. Moderate and severe will be your cerebral palsy, maybe needing round-the-clock care, through to cerebral palsy with a bit of developmental delay. And if we look at 23-weekers, half of the children at the age of 3 who are at home have normal or mild disabilities, and half don't. If you ask doctors that, paediatric doctors, older paediatric doctors, they will tell you, and just ask them what's their ballpark figure, they will say there's no point resuscitating 23-weekers because they're all damaged. And it's not, it's because they only see the ones who are damaged. So there you go, just to summarise what we've just said. So back to this lady, and I said we'd come back to it. No other population in which, let's say, it's 50% survival rate and a 50% rate of normal outcomes among survivors would be seen as dismal enough to defer life and death decisions entirely to the family. And yet that is what we do. So she's saying, actually, why do we go to preterm infants, parents, before they're delivered and give them the option of not resuscitating their 23-weeker? It's a debate I don't really think we should go into this morning. But so back to this little girl, Willow. Very briefly, she had all of the problems of prematurity. So she had this thing called necrotizing enterocolitis. She had 2 operations. She had chronic lung disease, bone fractures. She was intubated for so long, she got granulomas on her larynx. She had a patent ductus arteriosus that wasn't operated on. Most aren't. They're usually benign conditions. She had 3 episodes of sepsis. She had laser treatment for ROP. We've diagnosed with CMV infection. You don't need to know what these things are, but you can see she had a very difficult course. And we waited for something bad to happen. Well, on day 161, at term plus 6 weeks, something happened. And she went home. And that's her going home after 6 months of intensive care. Her family gave me permission to use these photos because I met her actually not in a week. I told you it was all in a week. I actually met her when I was a registrar in training towards the end of my training. And I learnt an awful lot from her. Because I thought there was no way she's going to make it. So I also realised the more I know, the less I know. Right, so that's that baby. The next baby is this baby, a bigger baby. This isn't the photo of the baby. There's no way we would wrap a cannula like that. That's just awful. But this baby was phoned through from the Isle of Man. It was born at 33 weeks and at birth needed resuscitation. She was now 5 days old, not breathing. He was not breathing because there's floppy undescended testes. Well spotted, thank you. And has been brought over by an ambulance. So this is an example, because we're a tertiary service, we get referrals from all over the UK. We are the local neonatal unit for the Isle of Man, but we work nationally with our neonatal units throughout the country, because if a woman goes into labour in Liverpool this morning, there's no intensive care cots. We need to get her to an intensive care cot for a baby. The nearest one might be Manchester, or it might be Newcastle. And so we've been in that situation where we've been the nearest intensive care cot for a baby in Brighton and a baby in Aberdeen. And so they've come all the way down to Liverpool to have their babies and cared for. We've also had babies transported to us from Kazakhstan and Miami. But those babies were Liverpool mums who were on holiday, who went into labour, delivered their baby early, and then they're bringing their baby back. So we get these sorts of things happening. So this, so the Isle of Man said, we don't know what's wrong with this baby. It's really easy to ventilate, but just is not breathing at all. Can you help us? And so we did the ward round. It was really good that actually this was the first week of junior doctors rotating. And I have a joke in neonatology, we very rarely make a diagnosis because all of our diagnosis is prematurity. And so on the first week, for one of the first ward rounds, we went round and the mum came in and said, "Oh, good morning, my name's Chris, one of the consultants, nice to meet you." And I shook her hand and she was a bit younger than this, but she looked a bit like that. And I made the diagnosis in front of all of these new doctors. So I looked like house, even though it's like the first diagnosis I've made since 2004. But does anyone know what the diagnosis might have been? No, but good guess. It's the other one. Who? I hear someone's going. What was that? Sorry. Shout out. I've no idea what that is. What was it? Lampeter syndrome. Still no idea what that is. That must be a final year revising for final. Are you a final year revising for? I remember knowing all this stuff as a medical student, and you qualify and you realise most of the time you're diagnosed in croup and bronchiolitis, and you forget all stuff like that. But no idea. Okay, myotonic dystrophy. Yeah, so when you shake the hand and they have that slow release, it takes a long time for them. And the mum didn't know she had this diagnosis, which is quite common because you get that trinucleotide. Does any of this ring a bell? CTG, trinucleotide repeats in the increase with each generation, so each generation is more affected. So usually when you diagnose a neonate, you end up, I think on average, the muscle guys tell me you end up diagnosing 6 or 7 other people in the family who've got the same problem. So in her family history, there was a auntie who had cataracts at like 35, 40, which was unusual. And there was a grandma of another case very similar to this, but the grandma who was in Aintree Hospital at the time with swallowing difficulties, that was her symptoms. And she was having lots of investigations. And it was one of the greatest moments in my career to phone up a very arrogant adult registrar from a neonatal unit and say, "Oh, Mrs. Smith, you've got on your ward, yeah, just tested for myotonic dystrophy." "Oh, what do you know?" Like, slam it down. Neonates, if they get it, are profoundly hypotonic and don't do anything at all. You literally ragdoll. But they get stronger over the next 2 to 3 months. And so the plan for this little one was to ventilate for 2 to 3 months, then long-term ventilation. We'll need multidisciplinary team input and then get home in about 6 months' time. We've had a few of these where we've diagnosed them in the newborn period. So the next baby, anyone know what that is? Yes, not gastroschisis. Gastroschisis is the one that looks even worse. It's where it's all out and it's not inside the bag. That's an exomphalos. And that's got bowel and liver in it. So this baby had exomphalos, kyphosis, had pulmonary hyperplasia, so lots of congenital anomalies. And something we are seeing in fetal medicine now is, whereas in the past a lot of these fetuses would be aborted, now they are continuing to full term, delivering them in the hope that the fetal medicine doctors are wrong. One thing we are seeing is people getting 5, 6, 7, 8 different opinions for fetal conditions, which I think is also happening in paediatrics, wanting second opinions a lot of the time. So a lot to do with this baby. We had to update the family and move this baby to Alder Hospital. So that was a baby, just to show, we have these babies, we have lots of procedures and surgical stuff. The next baby looked a little bit like this. So an ex-preterm baby was 23 weeks, 440 grams, who's now 3 weeks old. Had that neck again and operated on, was renal failure, sepsis, ventilated, but had a normal brain scan. And the renal failure had led to them becoming very, very swollen and edematous. And these babies become just edematous all over. And their skin was starting to split because they were so swollen. And the question arises, is it in this baby's best interests to continue? And when we're faced with something like that, personally, and as a group, we will voice it in different ways, but the way I voice it is in 3 questions really. Is there any chance of survival? If they survive, will their life be of such poor quality that it's not in their best interest to continue? And is the child suffering unbearably, even if there would be a normal outcome for this baby? Is it in their best interest to put them through them having split skin, the pain that endures, months of intensive care, even if they end up with a normal outcome? And are we providing treatment or torture? And I use that phrase with parents because it's quite an emotive phrase, but I think boils down exactly what the issues that we're dealing with. So we had full discussions with parents. They understood the implications, and their view was that we will leave it in God's hands and a miracle will happen. It's just to say that we have discussions like this all the time, and you'll be aware of this high-profile case in Alder, and I'm not going to speak of the specifics of that case, but it's just to say to you that the reason it's high-profile is because it's made it to the court and made it onto the national press. But these discussions with families happen in every intensive care unit, at least 2 to 3 times every week, and they don't make it to the press. And the reason they don't make it is because families and parents come to agreement about what is the best way forward, and it's exceptionally unusual for families and doctors not to agree with what the right way forward is. Having said that, I suspect it's going to become increasingly so that families will disagree with doctors, given these 2 high-profile cases and others actually that are happening in the country. Right, so neonatology, why is it great? It's great because it's really sick patients. You go to work, you know exactly what you're going to deal with. There's no surprises, and most of them get better. The quality adjusted life years gained is potentially huge. So if you have a 23-weeker you instigate treatment on, and they make it home and they are in the 50% who are normal to mild, you're going to get 80, 90 quality adjusted life years out of that child. Compare that to adult intensive care, where certainly until recently, something like 70 or 80% of those who are in intensive care were dead within 6 months, having difficult, painful treatment. Well, you know, where should you be throwing the money at? Probably not adult intensive care. And I still think this stands now, even though I've said we're increasingly seeing families challenging decisions, that if babies make it home, the families are eternally grateful, and they will come back year after year with their 1-year-old, 2-year-old, 3-year-old, 4-year-old, 5-year-old to show them the doctors and the nurses who looked after them when they were little. And Lee Butler, he's a local DJ bloke, I don't really know him, but he had triplets, I thought, 22 years ago, and recently had a big fundraising event for these triplets, and when he showed one of them, he was like 6'4" now, and saying how he's eternally grateful for the women's hospital. These people just throughout their lives remember that difficult time. So you're doing a good job, hopefully. But if they don't make it, generally the parents are really, really grateful that you tried and that you gave their baby a chance. It's great because you're dealing with ethical issues, and we've touched on some of those this morning. You're dealing with families. There's lots of procedures to do. There's chest drains, there's lines, there's echoes, there's intubations. There's adrenaline emergencies, which means you give adrenaline to the babies, but more you give adrenaline to yourself. Things are exciting. It's multidisciplinary, which is really good because we get discussions with obstetricians and nurses, midwives, physiotherapists, other health professionals, SALT, community peds, and most of all the families. It's not great because it'll be 24/7, certainly by the time you qualify if you become paediatricians, but I suspect the whole of paediatrics and probably the whole of medicine will be 24/7 consultant delivered care by the time you arrive. It's very specialised, which can mean you get a lot of calls from around different hospitals in the region. Expectations are shifting, as I've alluded to, from parents, so that comes with it, the problem with litigation. So the biggest reason neonatal parents sue hospitals is 23 weekers survive all of this care, and they may be left with cannula scars from a cannula that's issued, and they'll claim for the cannula. It's not that often it happens, but it's a little bit off-putting when it does. And then there's this perception that we've touched upon that 24, 23 weekers are valued less, and actually babies aren't as human as older children and adults, which you end up being the voice of preterm infants, which is probably what I've done a bit this morning. I did this presentation 3 years ago, and I looked at this presentation last night for the first time in 3 years and realised that that was my, who's now 3-year-old, taken like when she was about 6 weeks old, so on my belly, and I put it in the presentation last time, and I've not changed it, so that's her, but she doesn't look like that. But that's a baby, anyway. So that's the end. Any questions or comments? Hello?
You know the survival study that's been done since 2006, you think they'll be doing another one?
I think we should. But it's huge financial implications. The question is, what would it change? I'm not sure. All I can tell you now is we're starting to see people. There used to be a big debate about should we resuscitate 23 weekers, given that data. That debate's pretty much gone now, because I think we're seeing 50% survival. But it's not surprising, you see, if you do something to 23-week babies and you really try, that some of them will survive, whereas if you don't do anything, they're all going to die. So we're seeing that now creeping back into the 22-week stage without any evidence really to support us doing that. The 22-week survival in Epicure was minuscule. But because the 23 weeks has shifted, we think maybe the 22 will shift. And then every so often you'll see in the press a 21 plus whatever in America's survived, who weighed 290 grams or something. And you'll have parents who'll say, but look, this one survived, will you not do anything? So in short, I think we should, but I'm not aware that there's any plan to do that as it stands. Go on.
So kind of leading on from that, do you think that any of this could affect the legal termination limit that's generally like 24?
Yes, I often get asked that question when we talk about 23, 24 weekers. You can't, my own view on this is you cannot, I've never come up with a thought that, or how can I word it? I can't rationalise those two things. I can't explain. I have personal views on abortion and women's rights and all that thing, and I have personal views on 23 weeks. I don't try and mix the two. I leave them separate because you can't. There's no way you can rationalise that. All I'd like to say is there's a whole debate that doesn't happen about feticide, and babies who've got major congenital anomalies can have feticide up until 2 minutes before they're about to deliver at term. So, and there's reasons for that. And when we see that, that happens at the women's hospital. It's not that often, but there's certain situations that'll happen. No one talks about that. The 24-week abortion limit is based. People have strong views on that because of the social reasons why people may want to abort fetuses and can do that up to 24 weeks. But the number who will abort them at 20 weeks and above is very, 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 very small. And that's as sitting on the fence as I'm going to be, because otherwise you get into a huge debate. But I keep those two things separate. I don't try and merge the two arguments. Anything else? Well, go on, right in at the last minute.
How is like neonatology and paediatrics going to respond to the cases that keep cropping up? Is there a way for like that parents who end up in these situations are better informed, or like what do you think happens there?
Oh, I'm going to have to be very careful how I answer that question. I think what you need to know is, as I said to you earlier, that there's thousands and thousands and thousands of these discussions happening all the time, and you'll never hear about them. Probably every time I do an intensive care week, 2 or 3 times that week, with 2 or 3 different families, you'll be discussing those issues. And families are well informed. The question comes down to, in most cases, about the value of life and what you perceive as being a quality of life. And I think we're quite good at the Women's in acknowledging that what I perceive as a quality of life, or my colleagues do, may be different to what a family perceives as a quality of life. And you need to explore that, and you need to keep them on side. And don't think for 1 second that these cases have started off with the doctors over here, the family over here, and never meeting. There'll have been endless discussions to try and get to some form of agreement. But if fundamentally the doctors are saying, this isn't a quality of life, and this baby's suffering, and the family is saying, I think being alive is enough for a quality of life. And I've had it the other way, just while I'm musing along, where we've had families who have said, our kid's going to be disabled, that doesn't fit with what we see as a quality of life, and they might be mildly disabled or they may have moderate symptoms. And they say that doesn't fit with a quality of life. Is there anything you can do to cause that child to die? So we get it the other way as well. And that's really difficult when we're being pulled to end a life that we think actually is worthwhile. And I've had it where families have been told your child's going to be severely disabled, and they've said, we don't want anything to do with that child, can you please get it adopted, fostered, but we don't want anything to do with it. So everyone's got a view on where your quality of life is, and it sounds like these big cases have been about what is their view on a quality of life. So for some people it's merely being alive. I think personally for me it's being able to enjoy life, which would be able to smile and communicate, so receive communication and give some form of communication back would be a minimal quality of life. And for some people it'll be beyond that, and you'll all have your views on where quality of life issues are.